Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare.
All right, guys, do we have a special treat for you today? As you know, we spend a great deal of time exploring how to remain and or get healthy on this show. And one of the leading causes of sickness in the developed world, at least, is cardiovascular disease. Over the past year or so, we've been looking far and wide to bring on a special guest to take a deep dive into this crucial topic. And our guest today is truly an exceptional person who understands and shares a passion for preventative cardiology. That person is none other than Dr. Nicole Harkin. Dr. Harkin attained her medical degree from Boston University and went on to complete her internal medicine residency at Columbia. She stuck around NYC for a fellowship in cardiology at New York University, in which she served as a chief fellow. She went on to complete advanced training in clinical lipidology, which is where we will spend a great deal of time today. You'll find that this can be a complex yet important topic to understand if one is to prioritize mitigating the risk of the leading cause of morbidity and mortality worldwide. Recently, Dr. Harkin moved to San Francisco with her family and founded Whole Heart Cardiology, with the mission of providing patient-centered cardiac care, evidence-based nutritional guidance, and personalized lifestyle plans for her patients in a modern setting. So in this episode, we touch on various topics, including, of course, her journey and passion for lipidology. We talk about the current state of metabolic ill health in developed countries. We then shift gears and touch on the various ways of risk stratification, which include diagnostics. Seeing as she is an expert in lipids, we discuss, both normal cholesterol and quote unquote good versus bad cholesterol and some of the basics in that sense. We also talk about routine and more advanced testing, some of which I've become very invested in, things like just ApoB, LDL particle numbers and size, and of course, Lp(a), which is an extremely important thing for us to understand, both for ourselves and our patients. We also talk about other metrics she routinely uses, such as imaging modalities. We briefly touch on some treatment strategies, and of course, no conversation of cardiovascular disease and lipids is complete without the discussion of statins, which are highly prevalent in today's society. Overall, I found this to be an extremely enjoyable episode, and there was so much we wanted to cover, but just unfortunately ran out of time. Fortunately, though, Dr. Harkin agreed to sit down for part 2, which will be released right after this episode. Now, without further delay, please enjoy this episode with Dr. Nicole Harkin.
Dr. Nicole Harkin, thanks so much for coming onto this podcast.
You're so welcome. Thanks for inviting me. I'm excited.
Absolutely. So, Altamash and I have had Medicine Redefined now for about a year. And for a year now, we've been saying we need to talk about cardiology, right? The number one leading risk factor and death, when we talk about being healthy and lifespan, longevity. So finally, you made our wish come true. So again, thanks. But I really want to delve into your journey, right? I think there's a lot of pre-meds and medical students who think about going into cardiology, when they think about medicine. What made you choose cardiology? Take us through back then, a little bit about your journey.
Yeah, absolutely. So I started actually thinking, I was kind of a late bloomer into cardiology. I feel like a lot of cardiologists you talk to, they've known they wanted to be a cardiologist for a really long time. I sort of came into it later in my medicine training. So early on, I was actually, and remain interested in, but very, very interested in global health and international health, and did a lot of work abroad. And so at that point, I really thought I was going to be an infectious disease doctor, which kind of is a natural complement to that experience. And so throughout medical school, that's really what I thought I was going to do, and thought I was kind of going to do a public health sort of dual degree and things like that. And then eventually started kind of getting interested in cardiology. I think a lot of that started actually when I was in Africa, and obviously a lot of my work there was infectious disease related as well, AIDS and TB and things like that, but started to actually really truly understand the global impact that cardiovascular disease has. So it is the number one killer worldwide in every country. And so just seeing just rip-roaring uncontrolled hypertension, lots of premature heart disease and things like that, and started and that's kind of, I think, when the first light bulb went off, like, oh yeah, like there's a lot else out there. And then, I mean, the heart's cool too. So then I started getting really, I mean, it's the physiology of how the heart works and all the things that happen is really just intellectually very interesting as well. So just really started kind of thinking about that. And then I went to Columbia for internal medicine residency, and it's hard not to like cardiology there. The cardiology department is huge there, very influential. Did a whole rotation there and just really kind of fell in love. And so ultimately decided to sort of marry my two interests in kind of preventive health and cardiology, and really kind of become a preventive cardiologist. So that's when I, in fellowship at NYU, they have a huge preventive cardiology group there. So worked with them a lot, which was a great experience, and I can talk about that more. And then eventually decided to get boarded in clinical lipidology. And that's sort of where all of that experience kind of evolved for me.
I love that. I do agree. The heart is very, very cool. And I always tell my colleagues that, in another life, if I didn't go down the sports medicine pathway, which is my calling, I certainly would have done cardiology. And yeah, you've had a long journey, right? I mean, so 3 years of internal medicine, 3 years of cardiology, and lipidology. Is that more fellowship time, or do you just sit for boards on that? How does that work?
Yeah, so it's just really independent study, and then you sit for additional boards. So the National Lipid Association has kind of some self-study stuff that you can go through and go to some of their conferences. They've got like a crash course for people that are looking to get into lipids, and you can attend the conference and then take it. And was definitely mentored by many at NYU. I actually was the first general cardiology at NYU to take those boards and pass them. So that was kind of exciting.
That's awesome. And I agree. As you alluded to, that cardiovascular disease is the number one killer globally, right? Particularly in the developed world. I mean, that's certainly the case. And we've talked about metabolic ill health several times on this episode, right? And I think this stat that I've thrown out several times, I wonder if 43% obesity in this country, in the United States, right? And the expectation is that in another 8 years, that's going to be 50%. And I shouldn't say this, but I think largely lack of education isn't a problem, right? We spend a lot of time talking about fruits and vegetables on this, and we can do all these things, yet people continue to get, unhealthier and healthier. Recently, a study that I can't remember, but I think it was 2018, was published that 88% of Americans had at least one marker for metabolic syndrome, right? I think that the most recent data, when you look at weight gain during the COVID-19 pandemic over the last 2 years, in just not only the adult population, but in the pediatric population, I think there was some stat that between the millennials, which I think all of us are millennials probably, it's like 25 to 40 something pounds. So, I say all that to say that it doesn't seem to be getting better despite all the information that's out there. And one of the things that, taking all those things into account, that's important for us to do is spend a lot more time talking about risk stratification and diagnostics and things, that how can we identify these things earlier on, which is what you're passionate about, right? Preventative cardiology, rather than later on sick care, And so what are some ways that you tend to detect disease much earlier on? Maybe not in people in their 50s and 60s when people really start worrying about their heart health, but 20s and 30s.
Yeah. So, we have a pretty robust understanding of the major risk factors for cardiovascular disease, right? And I think in general, we don't do a great job of employing those tools and using them on a regular basis. So I don't know what the stats are for how many millennials have a primary care doctor or have ever seen a primary care doctor, but I'm sure it's like pretty low. So unfortunately, what happens is a lot of people don't get screened early on. And don't identify, cholesterol, high blood pressure, all of these things that we should be screening for on a regular basis, right? And so, just kind of even taking some of the traditional risk factors that we know about, high blood pressure, BMI, smoking, all the usual suspects. I think that those don't get identified early enough on. And that's just kind of some of the stuff that we all know, right? That's even before you get to some of the more advanced stuff, which I'm sure we'll talk about in terms of really fine-tuning risk and looking at different advanced cholesterol markers and in early signs of insulin resistance and all of this other stuff that we should arguably be doing as well.
Dr. Harkin, at what age would you say you would typically look at risk factors then? I would assume when you look at the ASCVD, it's like 40 to 79, right? I think for optimal results. But now when we see obesity rates climbing so high, are we looking even younger, less than 20 maybe, to kind of look at these lipid panels, for instance?
Yeah, no, for sure. So pediatricians are supposed to draw cholesterol panels in all children at some point. And there historically, it was because we were screening for genetic dyslipidemias, right? So, kids as early as 8 can go on statins if they have evidence of a very elevated LDL cholesterol, which is diagnostic of familial hyperlipidemia. So traditionally, that's what we were screening for. But if you talk to pediatricians now, they're actually screening them early for, and they check blood pressure and things like that, but they are seeing blood pressure, cholesterol, BMI, as you mentioned, in adolescence. And so now we're not only seeing evidence of genetic dyslipidemias and issues of true genetics, but really truly lifestyle related elevated risk of cardiovascular disease. And that's truly scary because in the prevention world, we talk a lot about primordial prevention, which is like really starting young. Well, what's primordial prevention anymore? Is it, in utero? So I think that the ball feels like it keeps moving in terms of, okay, in the cardiovascular world, we have lots of conversation about this blurred line now between primary and secondary prevention based on some of diagnostics and things like that we can do now. But I even feel like we're blurring the lines completely and totally. And we know from studies decades and decades ago that that young men and women who died of other causes, if you look at, so I don't know if you guys are aware of some of these studies, but from decades and decades ago, I think it was even the Vietnam War, they would do autopsy studies and look at men and women who had died in war. And there was already signs of atherosclerosis. These young people, and this was then. I'm sure that is even worse today.
Absolutely. I mean, I think in all of our pathology classes, we learn that this, the atherogenic process begins in your teenage years, right? And it's kind of exactly what you're describing here. So let's dive a little bit deeper into, we talked about the lipid panel. You've alluded to LDL and how that can be diagnostic when it's extremely high in the pediatric population. For those who might not know, what are the different things that would pop up on a lipid panel, like total cholesterol, and then from your cardiologist's eye, what stands out to you most? What are you looking for? What do you make of the lipid panel?
Yeah. So if you go to your doctor, the traditional lipid panel that you'll get is something that's comprised of the total cholesterol, which is all the cholesterol that we can measure that are contained within the lipoprotein particles in our bloodstream. And then that gets broken down into HDL cholesterol, LDL cholesterol, which is calculated, and triglycerides. So LDL cholesterol is what I mentioned. It's calculated based on the other parameters, and that is a measurement of the amount of cholesterol contained within your LDL particles. And that's important and does not get discussed enough. And we'll get into why that's important. But it is it is a lot of people think that that's kind of the end all be all number. And first of all, it's calculated. And second of all, it's the cholesterol contained in the particles themselves. And so the reason it is important to look at your LDL cholesterol is that is where most of our data is at this point in terms of what does an elevated LDL cholesterol mean? And we have tons of data, Mendelian randomization, epidemiologic, RCTs, all of this that lines up that shows that as your LDL cholesterol goes up, your risk of cardiovascular disease and death from cardiovascular disease goes up. And as we lower it, your risk goes down as well. And so that's where a lot of our data is. And it's a very strong correlation and a very robust correlation. And so much of the drugs that we use are the first line offense against cardiovascular disease is working on lowering that LDL cholesterol. And so that is our primary target. And will probably remain so for some time in terms of trying to get that to a lower level to prevent cardiovascular disease because it is causative. It is necessary to develop cardiovascular disease. And maybe it's worth briefly going into the pathophysiology of what is atherosclerosis. I don't know if that's worth it or not. Yes, no?
Yeah, yes, absolutely. Please. Yeah.
So super high level of it is, as I mentioned, these lipoproteins, predominantly your LDL particles that contain cholesterol that are thought to be atherogenic. And there's also VLDL and other types of lipoproteins, and we can get into those at some point. But those are the primary, in most individuals, the largest population of atherogenic particles are those LDL. And so what happens when that concentration of ApoB containing lipoproteins is elevated, that concentration is higher in the plasma and then diffuses across the endothelium into the arterial wall. And through complex things that occur, the LDL cholesterol gets oxidized. That's highly pro-inflammatory, and you get the beginning stages of an atheroma. And so, and then as those sort of grow, then you can get different complications, either obstructive coronary disease, which is when that plaque becomes large enough that it's obstructing the blood flow to the heart, and that's when people get angina and chest pain, or you can also get a myocardial infarction, which is when that atheroma actually bursts. Actually, one of my mentors always compared it to a pimple popping, which I think is absolutely disgusting, but very you can just visualize exactly what's happening. And then that sets off the inflammatory cascade and coagulation cascade, and you get a clot that forms kind of on that. And that's a myocardial infarction. And so those are kind of what and importantly with that, studies have shown, and it's somewhat controversial, but studies have definitely shown that it's not always the biggest, when we're looking at casts and things like that, get nervous about the 80 and the 90% lesions, but sometimes it's those 20 and 30% that can cause the MI. So that's what we're trying to prevent. And endothelial dysfunction is important and allows those atherogenic particles to get into the endothelium more easily. So smoking, obesity, all that kind of stuff hypertension, make our blood vessels more prone to allowing that cholesterol to deposit. But you have to have cholesterol in order to make a plaque, right? And so while it's important, obviously, to control these other risk factors, if we really control and lower that concentration of LDL particles in the bloodstream, we can really prevent the deposition and then therefore coronary artery disease.
I love that you said that. And it's funny because you started off with this is going to be a high level discussion, which it is. And I think that for you understand that. And I think for most people, when they look at a lipid panel, they kind of just characterize good versus bad cholesterol, right? Like, oh, HDL high, good, LDL high, bad. And it's much more complex than that, as you just briefly touched on. You mentioned LDL particle number and particle size a couple of times, or you alluded to at least particle size. And I want to go down this rabbit hole a little bit further, because there are some people who will talk about how it's critical for us to evaluate particle number and particle size, because that's really what matters, right? And you kind of mentioned that LDL is calculated, the LDL-C that's typically shown on a lipid panel. And so say a little bit more about why it's valuable, if at all, in your experience, to check, an LDL particle number and size, and what that means, in terms of small, medium, and large LDLs.
Yeah, so this is somewhat controversial, but and it remains that LDL cholesterol is, for many, a very good indicator of cardiovascular risk associated with your cholesterol. That said, it misses many people, and in particular, it tends to miss, and I have seen this time and time again in individuals in whom there is the risk factors of metabolic syndrome, obesity, et cetera. And as you mentioned, now 42 to 43% of our population fits that criteria, at least has obesity and is likely also metabolically, has some metabolic issues associated with it. And so in that population, the association, the discordance between your LDL cholesterol and the number of particles you have is higher. And so you will underestimate their risk associated with LDL cholesterol if you're just looking at that LDL cholesterol. And so what I mean by that is that as I said, for most people, when you measure the cholesterol that's in these lipoproteins, you're getting a good sense of about how many they have. Now, in individuals who have very high triglycerides and metabolic syndrome, you tend to get several. So instead of having, say, 5 large, fluffy LDL cholesterols, you'll have 10 small, dense LDL particles. And what we've shown in those individuals is that those who have this LDL discordance, meaning they'll have higher ApoB or LDL particle, however you kind of want to measure it, then their LDL cholesterol would lead you to believe. So you'll get their LDL cholesterol back, their standard lipid panel back. Oh, your LDL cholesterol is, 95 or 100, and not so bad, right? But then you draw an ApoB or an LDL particle on them, and their risk associated with that is much higher than you would anticipate based on their LDL cholesterol number. That's discordance. And their risk is, studies have shown that their risk of cardiovascular disease in those individuals is much more closely tied to that elevated ApoB or LDL particle. And so that's where measuring those kinds of numbers can be really important and dramatically impact that individual's risk modification strategy.
Gotcha. Now, in a standard lipid panel, we're just getting the concentration number, correct? We're not getting the particle number.
Yeah.
For LDL.
So you're just getting the LDL cholesterol is 100 milligrams per deciliter, correct?
Okay. So then in order to obtain the particle number, is that you would have to do a separate test for that? Or
yeah, so you can order ApoB separately, and many people are doing that. And in fact, if you look at the European guidelines, they really are taking that into account and recommending that it's considered a secondary marker, but the European guidelines do kind of mention ApoB as something to follow as well, and kind of do outline some of what we just discussed. So you can order that separately. If some people also do what's called like an advanced lipid panel, and you can get it through Quest and LabCorp and all your usual suspects, and that will give you sort of the LDL particle number, and then give you the sizes and things like that.
This might not be a great question to ask, but when you're looking at the advanced lipid panel, you're looking at LDL particle number. It shows LDL particle number. It'll show small, medium, large. Am I missing anything? What else will it show?
Yeah, and then it does look at like the HDL sizes and things like that. But
if you use that to treat, do you ever use the particle number to treat?
Yes.
Okay. If you're using that, are you more concerned with the small LDL or the number of small LDL, or are you looking at the total amount of particle, like the LDL particle number?
So I think the data is stronger when looking at counting numbers of atherogenic particles. So whether you're using ApoB, which is capturing kind of all of the atherogenic particles, or LDL particles, that's kind of looking at numbers. That to me has the better data behind it in terms of more closely estimating cardiovascular risk. And so I tend to pay attention to those more. Typically, though, in individuals that you see this discordance phenomenon in which case measuring those kinds of things is more important, they will have a predominant small LDL pattern. So you're kind of taking it in, it goes hand in hand, if you will.
I got you.
So you're sort of taking it into account anyway.
You mentioned at the outset that, it remains controversial, and you have eloquently described that in cases of discordance, which tends to be high with, again, metabolic syndrome. And I think for those who don't know metabolic syndrome, so the 5 things that, triglycerides about 150. Oh my God, I'm actually forgetting all. Somebody, you guys help me out. What are the other 4? I know your
waist circumference.
Waist circumference is 1. Your blood pressure, right? Elevated blood pressure. A1C of 6. How high is the A1C?
It's just glucose still.
Just glucose?
Yeah.
What's the last one?
Over 100, and then HDL. Low HDL.
HDL, right? Low HDL, lower than 40? Is that what it is?
40 or 50 on your male.
40. Okay. So and we mentioned again, recent study showing that 88%. We talked about the obesity numbers. Why not use LDL, right? If we know that if we have compelling enough data to support that when you have discordance, and again, I think we've all made the argument that metabolic syndrome is on the rise. Why not? Why is it controversial?
I'm not part of the guidelines committee. I think that, so what I would say is that, I think that we do have a robust data set looking at LDL cholesterol. It's what all of our clinical trials, for the most part, when you look at, using statins, PCSK9 inhibitors, all these drugs, the targets, the goals, the numbers are all based on LDL cholesterol. And so some of that, I think, to be fair, is because that is sort of what our data is on in terms of targets and things like that. I think also what's brought up is, cost, although ApoB is not very expensive at all to add on. So that is a little interesting to me. What I also hear is sort of making it more complicated for the average busy clinician to sort of sort through. We're all so, you see an LDL cholesterol number, right? And you kind of intuitively have a sense of, okay, that's high, low, or not. I don't think the average clinician, so we'd have to really switch over our thinking if we were to then focus on particles or ApoB or something like that. So, I think that these things take time to shift over in terms of kind of all of that stuff. I think that the European guidelines, I think, are a little bit more reflective of what a lot of us are doing, who are really, seeing individuals who, we really want to focus on optimizing heart health and not just like, oh yeah, oops, you had a heart attack. Let's optimize it early.
Preventing, that
heart attack, right? So, in terms of measuring Lp(a), they recommend checking that once in everyone, which I think is totally appropriate. So, I think things will evolve over time, hopefully.
Change takes time.
It takes time.
Absolutely. No, I do like that. And what's interesting, actually, a recent podcast that Alan Snyderman on Peter Attia's podcast just a couple of weeks ago, we'll link to that, and they go into depth and a lot of things that you just mentioned right there in terms of, at the individual level, why the guidelines are the way that they are. Of course, there's a lot of narrative in that rather than evidence. But if Alan Snyderman is, you probably, he writes a lot about particularly ApoB, and he's not necessarily on the guidelines as well, but he's got a lot of great work on this. So we'll link to that. But let's talk a little bit more about ApoB, right? I think that there is probably more of a consensus. You already mentioned that the European guidelines, I think you're alluding to the ones in 2019.
Yeah.
Is 2018 or 2019? Yeah. That are already using that and suggesting that this is maybe a good marker for, cardiovascular health. Some people, again, will argue that, hey, non-HDL cholesterol, which I think a standard lipid panel, it tracks it close enough. And I've had a conversation with 1 or 2 lipidologists who have made that argument. However, my just brief understanding of literature, the issues that you mentioned in terms of discordance for metabolic syndrome tend to be the same when it comes to non-HDL, right? Particularly when triglycerides are high, which we'll talk about in a future episodes, how it can be easily manipulated with diet. Non-HDL does not track well with ApoB. I'm curious to get your thoughts on that, and when it would be good to use that versus just get ApoB, that kind of stuff.
Yeah, so I think non-HDL cholesterol so before LDL particle and ApoB became a little bit more mainstream, that was definitely what I was taught to use, even more so above and beyond the LDL cholesterol. So I think that a lot of people call it the poor man's ApoB because it is in that panel already. And I think that it can be really useful if you don't readily have one of those other markers available to you. That said, when you look, most of the studies have shown that that ApoB has the strongest association in terms of cardiovascular risk, and it counts for all of those other things, right? So sure, LDL cholesterol is typically associated, maybe non-HDL is like a little bit better, but really ApoB has kind of takes into account all of these things, and is probably the most accurate thing to measure in terms of assessing cardiovascular risk. Does that make sense?
Yeah, absolutely. And again, just to kind of drive home that point, I would argue that ApoB, as you mentioned, it's going to be the lipoprotein that's going to be in all of these markers. You talked about IDL, VLDL, and although LDL are primarily the ones, as you highlighted, that are going to be responsible for atherogenesis and that process throughout the entire body, there is evidence to support that VLDL does that. In preparation for this discussion right here, I was just kind of doing some light reading on cardiology journals, if you will.
And, light reading in lipidology. I don't think there is any such thing.
Yeah, there. And as a
lipidologist, I'm like, oh.
It can be really fun. Like you said, you would really have to have a passion for it. And I saved this. Didn't really go through this, but this article in 2020, and it's actually in JACC, was published, talking about how VLDL cholesterol accounts for 1/2 of risk of MI associated with ApoB containing lipoproteins, right? And so my thought would be, why not? Rather than use the poor man's thing, why not just get the marker that's going to be, and you're going to capture what you're going to see in IDLs, VLDL. I think in a world where we're getting closer and closer to taking care of our patients at an individual level, like this word precision medicine, it gets used a lot. And why not check that? And so I have difficulty again, this is a non-cardiology bias. This is just a person who wants to optimize health rather than just treat people who are sick. But I'm from your sense, who has the wisdom, who've been in the conversation with lots of cardiologists, you've trained in some prestigious institutions. What's the argument on the other side about not doing it, at least in this country, in our healthcare system?
I think it is continuing. It's an evolving conversation, right? I think that it's taken, as with all of scientific endeavors, it takes time before something becomes more mainstream. It just does. And so, there isn't great arguments against it other than the ones that I mentioned, right? So people argue against cost, people argue against, really having to re-educate the general busy clinician as to what to look for. And so, do we overly complicate it? That sort of thing. And there are some that say that there's not, given our robust data with LDL cholesterol, there's not enough evidence yet that we need to necessarily pay attention to ApoB. I personally find that we have enough, and I think that I've seen it in enough, anecdotally, in enough of my patients. I have seen this major discordance, and where I get lots of patients who've just had a basic lipid panel. Oh, my doc's told me my cholesterol is fine. My cholesterol is fine. And then either they have an event, and so then they come to see me and they're like, what's going on? What happened? Or hopefully not, they didn't have an event, but they eventually found me, and we look at either LDL particle or ApoB, and it's definitely much higher than you would predict from their LDL cholesterol. And so, I think that given we have so many medications and lifestyle changes at our disposal to really lower risk due to cholesterol, it's in my mind, it's a missed opportunity.
I love that. And I think as much as both Darsh and I are passionate about, optimizing health and practicing precision medicine, I'm I think just as passionate about practicing cost efficient medicine. I think there's something to be said about that. I think in that episode that I referenced with Alan Snyderman, they actually discussed this issue. I'm not sure if you had a chance to listen to it, but Alan Snyderman practices in Canada, so they have different, obviously, but at least Peter T had mentioned that he called the lab, and I think it was $2.50 for ApoB, right? Something like that, right? I haven't verified this personally with Quest or LabCorp or whatever, but if it is, that doesn't really, so I don't,
in a
that
world in which
doesn't,
every patient in the hospital gets like, the regular
Exactly.
set every morning, and you're like,
yeah.
I think probably you can handle the 250.
So coming back to your practice, right? If a new patient comes in, maybe in their 20s, some individual, he's active, he's healthy, he, whoever, and they want to, optimize their chances of, living a healthy life and a longer life. What are some of the basic things that you're going to look at? Of course, I know you've talked about this. Family history is, super, super important, that kind of stuff. But aside from that, when you're looking at objective things, what kind of lab values really stand out in that initial consultation that you'll order?
Yeah. So there's definitely not, as you mentioned, I try to practice a both evidence-based and kind of precision type medicine. So there's certainly not kind of a one size fits all approach. But certainly I do tend to look at both advanced cholesterol panels, so many of which we've discussed already, the benefits of either an LDL particle number or an ApoB. I also almost always measure an Lp(a) if someone hasn't had that measured already. And we haven't touched on that yet at all, but
Let's do that.
I'm going to do that now.
Let's get into it.
Yeah.
A really important marker. So Lp(a), lipoprotein (a), is another. So as we've mentioned, LDL particles are kind of, for the average person, the primary atherogenic lipoprotein that's circulating in our bloodstream. For potentially as much as 1 in 5 of us, lipoprotein (a) may also be significantly elevated and a major risk factor as well. And so lipoprotein (a), it's basically like an LDL particle, except it has the little a moiety on it, which incidentally is very similar to plasminogen. And so that's thought to be part of why it has increased risk of thrombosis. So what we have found is that individuals who have elevated Lp(a) certainly have an increased risk of cardiovascular disease, and so it's Lp(a) is thought to be atherogenic, just like LDL cholesterol, and it is unfortunately genetically mediated, in that it's very much, and this is why the European guidelines recommend checking it once, and at least once in everybody's lifetime, because it's genetically mediated. So if you have it, you have it. And it doesn't appreciably change that much over someone's lifespan. In women, it does go up a little bit post-menopause, but that's really about it. It is influenced somewhat by diet, but not nearly as much as, say, LDL cholesterol. And so in addition to being associated with cardiovascular disease, atherosclerosis specifically, it's actually also, as I mentioned, associated with an increased risk of DVT-PE. And then it's also associated with an increased risk of aortic stenosis. And so those are kind of the things that we need to just be mindful of in individuals who have an elevated Lp(a). And I have plenty of patients who have had cardiac events, and that's really their only identifiable risk factor is this Lp(a). And so at the moment, we don't have any therapies for it, really. So statins, so as I mentioned, diet does not tend to change it dramatically. Statins, if anything, might increase it. And so really what we're left with is kind of niacin and PCSK9 inhibitors. So niacin can definitely lower it. It's pretty controversial to use it. I typically don't, but some of my patients have been on it for some time and are pretty want to stick with it. We don't have any outcomes data. So while we know that increased Lp(a) is associated with cardiovascular disease and causative, we actually don't have any data yet that lowering it will definitely reduce risk. So PCSK9 inhibitors are our best bet. They can lower Lp(a) by 20 to 30%, depending. It depends. And there's some signal that in individuals who had an elevated Lp(a), when they're on PCSK9 inhibitors, they had lower risk of events above and beyond what would be expected just by their LDL lowering. So when I have patients who meet criteria for PCSK9 inhibitors and have elevated Lp(a), I definitely encourage them to use them.
So, for people who are like kind of anti-medication, right, and we hear about this population all the time, if they get their Lp(a) measured, right, and it's high, are we measuring it just to see what type of medication and therapy we can use towards it? Because you said it's not going to change much, really not much effect from diet. So there's not much lifestyle modification that can lower the Lp(a). So are we really just drawing it to see what we can give?
So currently, how I use it most typically in my practice is really to be able to guide treatment decisions about other risk factors. So it is, and in our guidelines, it is recognized as a risk modifying factor. So certainly in individuals who have an increased Lp(a), my threshold for where I'm okay with their LDL cholesterol, for instance, or particle ApoB is really low, right? So I push those people down as low as I can. I really make sure that we're optimizing everything else that we possibly can because of what I've seen Lp(a) do.
Yeah, I think it was maybe a different podcast. I actually might have heard you say that diet, or at least maybe it was diet or a plant-based diet, tends to increase Lp(a).
It has. There was one small study where it actually increased. It's strange. I mean, some of the, like I said, but it's not. I mean, it definitely that goes along with the statin data, which also increased. So paradoxically, some of the things that we have that we know that can lower LDL cholesterol either don't do anything to Lp(a) or make it like a little bit worse.
So I don't want to go too far down this pathway in terms of treatment, but if you did get the Lp(a) and it was elevated, and now you're going to be, taking that information, you'll be a bit more aggressive in everything else that you do in terms of prevention, primary prevention, but also keeping in the back of your mind with the statin data. Would you still put somebody on a statin from a protective standpoint because that's strong enough evidence?
Yeah. So I definitely, and even though I know that it's possible Lp(a) may increase a little bit with statins, if their LDL is not where it needs to be with diet alone, I have a very low threshold to add it.
Do you find when you're having this discussion with your colleagues, possibly working in academic centers, that they are quicker to, or they put less of a fight to order this test? What's your sense on that? I
do think that Lp(a) is definitely way more recognized at this point. Unfortunately, I still think people are thinking about it too late. So again, but this is true of a lot of medicine, and exactly what you guys discuss a lot on this podcast is that, I hear my colleagues thinking of ordering it in an individual who's, 42 and comes in with their first MI and their LDL cholesterol is not so bad, right? Maybe this is Lp(a). Which is why I think the European guidelines that say we should all just get it checked at whatever age is a great idea, because I'd much rather pick it up before that 42-year-old had the heart attack, because and again, we don't yet have great therapeutics, so I'm not saying we 100% could, but I'd at least like to give it a shot.
I find that really interesting, because one of the things that we all learn, most of us, I should say, learn in medical school and during our training, is that you don't order a test unless you're going to know what to do with it, right? Unless it serves a purpose, right? We don't want to do unnecessary testing, again, for the cost of the healthcare system, whatnot. And kind of what we talked about, niacin is one treatment. I think that's very, very cheap. PCSK9s can be ridiculously expensive when you're paying out of pocket, and they're not going to be covered in a 20-year-old for primary prevention. There are some things out there. ASOs, I think, is antisense oligonucleotides, right? I mean, but that's like super, super early, and for ridiculously high risk patients, and somebody who's had already the 42-year-old who's had an MI and a couple of stents that you're talking about. But you mentioned that some docs might be quicker to order this test, but at the same time, we don't have much that we can do. Yet people will not order ApoB or LDL particle when we have therapies that we can, target them and kind of modify them, if you will. I find that interesting.
I can't say that I am able to explain that phenomenon.
Yeah, so. Do you want to say something about the ASOs, just so people have a sense of what that is and what your what your experience is, in terms of where we are with the current state of the evidence with that?
So, so in terms of, there is one medication that's in kind of late stage clinical trials that's looking at lowering Lp(a) in individuals who have established cardiovascular disease and are considered high risk. And so, I think we're at least a couple years out from that clinical data, though, was the last time I looked. I think it's like 2 years away or so. But I definitely, am letting my patients who meet that criteria know, because and again, to that point of what you've said about feeling like you're drawing something that you can't do much about, I think that's important, that in patients who do get this drawn and it is elevated, that you are able to educate and counsel them as to what the implications are of this and what they can do about it, so that they're not completely, totally defeated. So yes, I let them know that there are some medications on the horizon, but I think just being very aware and not just ordering it to order it and then not know what to do about it. Because I definitely have patients come to me and they are very fatalistic, and they're like, well, I'm gonna have a heart attack. And I can't do anything about it, and I can't take a medication about it. So you definitely want to make sure that if you are going to order something like this, you do know what to do about it. And right now, the state of affairs is really helping them get super aggressive about everything else. And that does give them back a sense of power, right? Okay, your LDL is currently 130. I wanted this, right? This is what we're going to do to get that down. We might not be able to do something about the Lp(a), but we can absolutely change your trajectory.
Yeah, and I think that what you mentioned right there is a really important point that needs to be, I just want to underline a little bit further. I think that, with the harm of, unnecessary costs aside, the harm that it might increase anxiety in a patient. And, Dr. Beth Frades came out a long time when we talked about her initial passion about what stress does to the cardiovascular system. And I think, we don't want to order tests. And if you're not going to be able to do something about it, and if the patient's not going to receive that well, that, hey, I can maybe take care of all these other boxes, that might end up doing more harm than good. So that we got to be cognizant of that fact as well.
Absolutely.
Yeah, Dr. Harkin, I wanted to take a step back to Lp(a). You talked about how our genes really influence this, and some of our audience might be thinking, well, I wonder if I have the genetics for that, right? Can you tell us which populations typically might have high Lp(a), worse cholesterol panels, et cetera?
That's a great question. I actually don't know the exact distribution in terms of which, ethnicities are more likely to have it or anything like that. As I think it is known some populations, but as far as I'm aware, I don't think that you'd be able to reliably say, oh, well, you're XYZ,
Gotcha.
so it's super unlikely, don't worry about it. I think that, as I said, with the European guidelines, they do think that it's, quite reasonable to screen one time in everyone. And again, keeping in mind some of the considerations that we've mentioned, it's very reasonable to check at some point, as long as whoever is going to be checking it has a game plan forward about what to do about it.
Gotcha. And I just want to clarify, this test is separate from the ApoB, correct? And the advanced lipid panel for listeners?
Right.
Okay.
So Quest, there is an advanced lipid panel. So Quest has several advanced lipid panels. They do have one advanced lipid panel that also has Lp(a) in it. LabCorp, it's a separate test. In Quest, there's one bundle that does include it, and then there's another one that doesn't. So it's highly confusing. So for your average person who's probably trying to order these. So yeah, but it's something that if you wanted to get drawn, and you felt comfortable understanding like what the implications are going to be, you could certainly talk to your primary care doctor and say, hey, I'm concerned about this. I'd like to get it drawn. I mean, I definitely think that the people who should consider getting it is definitely anyone who has premature coronary artery disease. I think that's a given. And then certainly in any of my patients who have a family history of premature coronary artery disease, that's definitely something that I think should be checked, because it's a common cause of familial premature CAD. So those are, I think, your average person, do they need to get it drawn? I don't know that we're definitely there yet. Certainly our guidelines don't support that. But I think in people who have some of these family histories, or that they themselves do, I think it's certainly warranted.
Awesome. So we've spent a lot of time kind of defining and talking about blood markers that might give us some insight into cardiovascular health, right? What are other tests, some objective measures, such as imaging and that kind of stuff, that you might pull out of your toolbox to give us some insight on how somebody's heart's functioning?
Yeah.
Or their risk?
Right. So I think probably one of the best tools that we have right now that I think bears at least a couple minutes of conversation on is the CAC score, or the coronary artery calcification score. For any listeners who don't know what that is, it's basically a specialized CAT scan that takes pictures specifically of and focuses on the heart, specifically the coronary arteries, measures and quantifies the amount of calcium contained within the coronary arteries. Many of us kind of refer to it as the colonoscopy of the heart, in that it's seen very much as a preventive tool. It is not to be used necessarily when people are having chest pain. It's more to look at disease with a preventive lens. It's sort of widely thought to be picking up, quote unquote, early stages of heart disease. That's a little bit of a misnomer, because calcified plaque is by definition old plaque. It is not new plaque. So really you're picking up old disease. But regardless, it is a great tool that we have at our disposal now. And so essentially how many of us use it is when you're trying to sort of further fine tune and assess someone's risk. And it can give you a really good view into what's happening with someone's coronary arteries. Some of the examples that, and in our guidelines, it's very much acknowledged as a great tool that we can use to try to help risk stratify people, particularly in those individuals who fall at, like, say, a borderline risk, like that 5 to 7.5% 10-year cardiovascular risk. Do we start statins? Do we not start statins? Or if a patient is sort of on the fence, if they want to start them, it can be really helpful to sort of see where they're at. So, there's a lot of great, robust data that we have at this point that it can really be value added in terms of risk stratification, specifically if a coronary artery score is 0 in the right patient. That can be helpful to help us say, okay, so far so good. Let's keep watching if someone is truly opposed to statin therapy.
Yeah, I think an analogy that really helped me, and I'm still in this from Peter Attia. I hope I'll paraphrase, because I remember him talking about how, a CAC will show you after the damage is already done, right? Like, for instance, if I did my training in Baltimore, and if you go to a place and you go to a home and you see jail bars on the windows, then you live in a bad neighborhood, right? I mean, that's kind of preventative. But a CAC, seeing a fleck of calcium or a CAC score on a young person, it's like somebody's already broken in and there's glass shattered in the back door. The damage is already done, right? And it's not, so in a 30-year-old, if you have some calcium there, then at that point, like, the red flag, the alarm bells are ringing, like, something is going on, right? That's an indicative of advanced cardiovascular disease at that point. Is that fair to say?
Yeah. So, and that's what I meant in terms of a CAC score of 0 in the right patient, right? So, it certainly is. So not only does the CAC score give you an absolute number, so it gives you, you're a 0 or you're a 10 or you're a 400, which means, and that's what I was talking about earlier with the lines blending between primary versus secondary prevention, because at that point you're secondary prevention. So it gives you that exact, that number, that absolute number, but then it also gives you a percentile. And it sort of tells you kind of relative to other people your same age group and gender, this is kind of where you fall. And so, the CAC score is great, but it has to be used in the right context. And that's why I think it's really important to distinguish that this is not the very earliest stages of coronary artery disease. To your point, this is healed up old plaque that has been there for some time. If you're seeing that in a 30-year-old, that's like, really, we need to get on this now. That is very highly concerning to me. And also, by that nature, you have to be careful in interpreting a coronary artery calcium score of 0 in a 30-year-old, because it should be 30. It better be 30, right? And so just because it's 30 or just because it's 0 in a 30-year-old, sure, I'm like, okay, this is good. You don't have any CAC right now, but it doesn't rule out soft plaque, right? Which is what I would expect that we would have in a 30-year-old. And so where the coronary artery calcification score is typically most useful is traditionally been used kind of 40 and above, and in super specific scenarios where you're trying to kind of figure out adding therapy or not.
So I want to switch to because we talked about statins quite a bit, and I think that we have tremendous data to support their role, in all kinds of prevention, and you've touched on those quite a bit, or at least you mentioned it quite a bit. But I'm wondering, before we do that, is it worth talking about high sensitivity CRP? Because I've heard you talk about that quite a few times, and I know you use it in your practice.
I do. I think we can definitely, that's definitely something I also tend to look at. And I think is, again, something that is recognized within the guidelines as a risk modifying sort of thing that you can kind of take a peek at and help you kind of make decisions. And so certainly we know, as we mentioned, cholesterol and elevated lipoproteins are a necessary in order to create atherosclerosis, but inflammation is also critically important as well, because that damages the endothelium and makes it more likely that we'll see that happen. And so we see certainly so obesity is an inflammatory disorder. So we see that in that population. We also definitely see it in kind of the autoimmune population. So we now know that individuals with lupus and psoriasis and rheumatoid arthritis are at much higher risk of cardiovascular disease, likely because of this underlying low-grade inflammation. We also see it in HIV and AIDS. So now individuals who are surviving and living long lives because of the amazing medications that we have, they tend to have very premature and really just definitely a lot of atherosclerosis, likely because of that inflammation. And so those are kind of examples of people that have known inflammatory disorders that we definitely see that association with. But it becomes just as kind of important in sort of the average person who has maybe metabolic syndrome or kind of earliest stages of that, or really early insulin resistance or something like that. So Hs-CRP can be something that we can measure to get a sense of what is that inflammatory state. It's associated with an increase, an elevated Hs-CRP above 2 is associated with an increased risk of cardiovascular disease. Rader's done those studies of, that residual risk, right? So even when we treat people with statins, we still see this inflammatory residual risk. Even though statins do, help have in terms of pleiotropic effects, they do reduce inflammation. I think, that next big area of research is how can we modify inflammation in a way that we reduce risk of cardiovascular disease, but also don't impair our ability to fight off infection. And so we're still obviously that's still kind of in process, but it's certainly something that we can look at. And in terms of what to do about it, definitely we do have some data to show that eating whole food plant-based diets can help lower inflammatory markers, along with lots of other helpful lifestyle changes, which I think we'll get into, I assume, on the next episode. But right. So that's one of the things I do look at, because that's something that we can definitely work on.
Okay. Well, I don't think this podcast episode can be complete unless we talk about statins, right? I mean, I think it is one of the most ubiquitous drugs we see, especially Altamash and I in the rehab world, right? I can't name one patient that comes through our rehab doors that hasn't been put on a statin. And I'm sure our audience have heard of statins, probably have, if they're younger, have parents or grandparents who might have been on it. But just from a basic standpoint, what are statins? What do they do? Why do we use them?
Okay, that's a big task in and of itself.
That might be a 3-hour topic. So,
okay, so given we only have a couple more minutes, statins are a class of medications. Okay. So they, super high level, they essentially block an enzyme within the liver that is necessary to synthesize cholesterol. And so actually the mechanism by which they lower our blood levels of cholesterol is actually because what that does is it makes the liver upregulate the LDL receptors on its surface. So then it pulls more LDL cholesterol from our bloodstream. So that's kind of super basic how statins work. And as you said, they are kind of the bedrock of preventive cardiology practices all over the globe. They are a class of medications that have been around for quite some time. They were absolute game changers in terms of our ability to lower cardiovascular risk. We now have decades and decades and decades of really sound, robust data demonstrating that particularly in secondary prevention, we reduce the risk of cardiovascular events, and by as we said, mostly by that LDL lowering effect. But also well recognized for sort of these pleiotropic effects, which are poorly understood, but definitely we see some anti-inflammatory effects and things like that. Because certainly we see that in trials where we look at initiating statins the day someone has an MI, when they get wheeled into the cath lab, they get their aspirin, and they get their stent, and they get their statin, and they get their high dose statin. And so we know, and we know that even within those first 30 days post-MI, people that get that high-dose statin early on do better. So there's clearly some other effects other than just that lowering of LDL cholesterol. So they are widely used, widely studied, definitely save lives. I'd be remiss if I did not mention that they do have some side effects, certainly, and some real ones. So probably, the most commonly complained about side effects are the myalgias, the muscle aches, things like that. Some of those are dose response. Some of those are sort of the effects. And there actually was a really interesting recent study, which I'm sure you guys saw, where they looked at that really they took so the sort of the nocebo, I can never say that word.
Nocebo.
Thank you. I say placebo just fine. I don't know why. It does not go together for me. The nocebo effect. There, I said it. So there's definitely been some studies where they have looked at giving patients placebos, and it turns out that we all just have muscle aches, right? Particularly as we get older, and you guys know, like, everyone has aches and pains. So ways that clinicians can sort of so anytime before I start a statin, I definitely start at a lower dose possible and work my way up. And then I also actually have patients do a muscle aches and pains notation. So I tell them to right now, pay attention to your body over the next day or two. What are the aches and pains you get? Write them down, because this is not the statin. And then when we start the statin next week, if you still have those aches and pains, that's not the statin, right? And so actually having people kind of take a catalog of those muscle pains can be really helpful. And I found that I get a lot less people complaining about those side effects. That said, I have had patients who have had true debilitating myalgias because of statins. And so that can be a really limiting kind of side effect. The other one that I do monitor and probably concerns me the most is just the diabetes risk. And it's there. And so we do have to just kind of be cautious and careful and monitor closely for worsening insulin resistance and diabetes.
I'm really glad that you brought that up. I think the study that you're talking about was published in BMJ 2020. I came across this one as well, but I think it's worth briefly mentioning. Basically, they took statin intolerant patients, right? And they put them into, they either gave them a placebo or a statin, and they repeated that 3 times, they repeated that 3 times, and there were 6 periods overall in random order, and the patients either got statin or placebo, and afterwards they were queried, and the patients weren't able to tell like when they were getting a statin versus a placebo, right? So they were able to show that, hey, it's not necessarily the statins. That being said, though, there are physicians who will argue that, these adverse events or effects, I should say, are much lower in randomized controlled trials than they are in clinical practice, right? Because again, the population for RCTs is much smaller than the amount of people in clinical practice that are seen that are taking statins. And, prior to just over the last couple of years, as I've looked at some of the literature, again, clinically or anecdotally, I should say, I do have a lot of patients in sports medicine and rehab who tend to be maybe a little bit more active, who will say, hey, listen, I don't like it. I don't like how it makes it feel. Mm-hmm. Again, we can argue it might be nocebo, but at the same time, there are some statins that are more likely to cause that. I mean, so maybe a case study here would be good, right? So let's say you get a young individual who's highly active, maybe borderline athlete, who comes to you and you want to start this because it seems to be appropriate. Is there one that you might reach for initially, considering that myalgias might be something or, that kind of stuff?
No. So I typically use if I'm using a statin because I want a desired effect, I typically reach for, and I see a very specific patient population that typically needs a lot of LDL lowering. So I am typically starting with kind of the big guns, if you will. So I usually am using rosuvastatin, low dose, but that's typically what I'm doing. I think it's easier because you never know who will have a problem and who won't. So I think personally, I start with what I would prefer to use. And then if that doesn't work, you change your game plan. So as I said, and then there's other strategies, you can go to every other day dosing. You can move to a different statin. So Prava, Pitava, if you need to kind of go to a different statin, you can do that. That's lower potency. Or, instead of up titrating, you say, Rasuva at 5 was fine, but 10 it's not, go back down to 5 and add Zetia, or go to every other day dosing and then try to work your way up. So there's different ways that you can kind of modify your dosing schedule as you need to if someone has side effects. But I'd prefer to start with what I want to use first.
Absolutely. Well, Dr. Harkin, I want to be respectful of your time. I know a lot of the topics we just talked about today will probably come up again in part 2. And I'm excited for part 2 because we're going to be talking more about lifestyle modification, the way you practice, kind of your day-to-day and what you do with patients. So definitely excited for that. But before we let you go, tell our listeners where they can find you.
Yeah, so I am typically most active on Instagram, so Nicole Harkin, MD. And then I also have a website, Whole Heart Cardiology, all one word, .com, and they can sign up for my newsletter. If people are interested in becoming a patient, I'm licensed in New York, California, and Florida, so I see patients via telemedicine in those 3 states. I think those are the main ways to get a hold of me and see me.
Yeah, gotcha. Well, awesome. Thanks so much. Excited for part 2.
Thanks, Dr. Harkin.
Sounds great. Thanks so much.
Thank you so much for listening to the show. I know it may have been a lot to digest, but man, is it important for us to understand. I encourage you guys to give it another listen and definitely tune into next week for part 2, where we talk a lot more about interventions and particularly lifestyle interventions for a healthy heart. But before you sign off, please remember the important disclaimer that everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your physician regarding any specific health-related issues. However, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this. And until next week, thank you for listening.